Good afternoon, everybody. We'll make a start because we're just on 1 o'clock and we are aiming to keep to time. This is a webinar, Living with Multiple Chronic Conditions, to make sure you're in the right place. It's a series of webinars, and the first one is about risk factors that lead you to chronic conditions and ways to mitigate these risks through following a healthy lifestyle. And it gives me very great pleasure to chair this session on behalf of Health Innovation North East and North Cumbria and Health Innovation Yorkshire and Humber. My name's Jane Skinner. I'm a retired consultant cardiologist and I'm now working with Health Innovation North East North Cumbria. Next slide, please. A little bit of housekeeping. If you could please make sure that your microphones and videos, both of them please, are turned off during the session to avoid any disruption. If you need to take a break, then please feel free to drop off the call at any time and rejoin. Live captions are available if required. The event is being recorded and will be shared afterwards, and you will also receive a copy of the slides afterwards. If you've got any questions, then please use the chat facility. We'll try and address the questions we can during the event. Some of them may be done verbally through the chat itself. If we've got time at the end, then we'll pick up the questions verbally. And if we don't manage to do any of that, then we'll follow up after the event. And if you can't see the chat or there are any other problems during the session, please email Sarah Black, whose email address is there. Next slide, please. Just a brief mention of health innovation networks. There are 15 across England, and just to put it into perspective, they were called AHSNs, we're now Health Innovation Networks. It's exactly the same, and we do the same thing, which is bring together the NHS, industry, academic, third sectors, and local organisations. Next slide, please. It gives me huge pleasure, having chaired a previous series of webinars with both our speakers, that they're able to join us again. Rennie Kateb and Helena Gregory. This is the first of a series of 4, and just the speakers are very mindful of not duplicating information between the webinars, and we are having future webinars on heart failure and CKD, obesity, fatty liver disease and diabetes, and then the last one will be about health inequalities. So if you think something has been omitted on this session, it's almost certainly coming up in future sessions. So do tune in to us, and those dates are available to you. So I'm going to hand over to Rani. He's a specialty consultant pharmacist in cardiology and cardiovascular clinical research in Leeds teaching hospitals. He has a range of responsibilities. In addition to that, is very well placed to give us to tell us about the risk factors. We're very grateful for him giving us his time, both from his clinical work, but also from his national and international advisory and other work capacities that he has. So straight over to Rani. Thank you. I think you're on mute, Rani.
Thank you so much, Jen. Thanks, everyone. This is an opportunity for us to dive into the world of living with multiple chronic conditions. This is webinar 1, and we'll be exploring the risk factors that lead to chronic conditions and ways to mitigate these risks through following a healthy lifestyle. These are my different commitments as highlighted by Jen. Thank you. So starting with chronic conditions have a huge burden, and they've killed at least 43 million people in 2021 globally. The biggest components, if you like, of chronic conditions that contributed to a lot of the global mortality, number 1 is cardiovascular disease, and it accounts for most of chronic conditions deaths. So I will be a little bit biased today, given my cardiovascular interest and specialty. But cancer comes second. It isn't my specialty, but I'll be highlighting the risks also reported around that. Respiratory disease is the third, and after that comes diabetes, with over 2 million people impacted by it, including kidney disease deaths, of course. So this is mortality overall. These four group diseases or chronic diseases account for about 80% of all premature chronic condition deaths. When we try and explore what risk factors seem to be contributing to the development or the exacerbation of these chronic conditions, you will find that smoking and tobacco use, physical inactivity, harmful use of alcohol, unhealthy diets, and air pollution all seem to be increasing the risk of dying from these chronic conditions. And there is a big burden globally around and initiatives around prevention, detection, screening, and treatment of chronic conditions by identifying these risk factors and dealing with them as soon as possible. So I've got some diagrams that I pulled from a website called Our World in Data, and this looks at the overall death globally. As you can see, that the burden of heart disease, cancers, and respiratory disease seems to, and diabetes to an extent, is what seems to be driving the bulk of deaths globally. And if you look at the UK in specific, focusing on disease burden measured using the disability adjusted life years, which measures basically the total burden of disease, you'll find that the biggest burden we have is from non-communicable diseases. The majority of these are driven by cardiovascular disease and, of course, cancers, and as well as other conditions. So this is a breakdown of that burden to the UK. Cancers are number one, cardiovascular disease. Of course, you've got musculoskeletal disorders, you've got neurological disorders, mental health, respiratory diseases, and also includes kidney disease and diabetes combined further down. And then if you want to look at the risk factors that seem to be associated or seem to be prevalent among cases of deaths, number one is smoking. So smoking clearly drives a lot of those chronic conditions, and it is one of the biggest risk factors associated with death in the UK. The second is hypertension. The third is obesity. The fourth is dysglycemia. And the fifth is high cholesterol. We probably won't be focusing cholesterol and blood pressure because these have been covered in other webinars, and we can probably cover more in the future. I know for NHS England, we are running a special webinar around cholesterol in February. We will be covering obesity in the coming webinar, so we won't be delving into it. Dysglycemia, I'll talk about some of it, but not in diabetes sense, because we will be covering that in future webinar. So that's kind of, if you look at cardiovascular disease, these are the main drivers. Cardiovascular disease is pretty much what we mentioned earlier on. But if you want to kind of distill it between cancer, diabetes, cardiovascular disease, and chronic respiratory disease, smoking, physical inactivity, unhealthy diet, and harmful use of alcohol would be probably the major four risk factors that drive these multiple chronic conditions. And of course, not to forget Alzheimer's disease and dementia, they share similar risk factors. Smoking, excessive alcohol intake and use, obesity, hypertension, diabetes, depression, all these are associated with Alzheimer's and dementia. So if I want to kind of tidy that up, you've got the behavioral risk factors, which we've just mentioned, the metabolic risk factors, which we have just discussed, and the environmental risk factors, which I won't be delving into. Probably will need a whole session to talk about what air pollution and initiative can be done to tackle that. So starting with smoking and use of tobacco, and that includes secondhand smoking, because secondhand smoking is very important and not to be neglected, as you'll see later on. So smoking is one of the main causes of premature death and preventable illness in the UK. Smokers have about a 50% chance of dying prematurely, about 10 years earlier, due to smoking, compared to those who are not smoking with similar risk factors. After the age of 35, smokers will lose around 3 months of their life expectancy for every year of continued smoking. About 15% of deaths in adults aged over 35 in England, or 35 and above, were attributed to smoking. So a huge amount of burden, and it causes many chronic conditions which lead to death, including lung cancer, COPD, and other pulmonary disease, and vascular disease as well. And sorry, there we go. So these are just some figures to show you how smoking contributes or is a risk factor for various most common chronic conditions. Cancer. Smoking is responsible for about a fifth of new cancer diagnoses in the UK. And more than a quarter of all cancer deaths in the UK attribute to smoking. 20% of all deaths from cardiovascular disease are due to smoking. Respiratory disease, I'd say about 40% of all respiratory deaths seems to be due to smoking. And smokers have a higher likelihood of developing diabetes, of nearly about 40% more likely to develop diabetes if you're a smoker versus those who are not smokers with comparable risk factors. So the risk, it isn't just confined to these conditions. As you can see here, if you are a smoker, you are 3 more times likely to have a stroke. You're 10 times more likely to have COPD. You are nearly 3 times more likely to develop liver cancer. And you are twice more likely to be hypertensive. And it goes on. So the risk is quite spanning, and smoking is one of those risk factors that, if tackled at a population level, it will probably have a huge impact, most likely, on all different conditions listed here. And not to ignore secondhand smoking, because when somebody's smoking nearby and you're inhaling their smoke, there's a lot of these chemicals actually that you're inhaling beyond the nicotine. And exposure to secondhand smoking increases lung cancer by 20 to 30% risk, and coronary heart disease by nearly 35%, breast cancer by 67%, and cervical cancer by 40%. So when we talk about smoking, it's not just the smokers, but the secondhand smoking as well. This is a very interesting study, it's the BMJ, where it looked at a retrospective study looking at survival about those who smoke and stop smoking. And what is interesting is the correlation that it had between when people quit smoking. So if somebody at the age of 60 years old decides to quit smoking, they gain 3 years of their life expectancy. If they are 30 years old, they gain 10 years expectancy. So the earlier you quit, the more you gain from your life, and you reduce your risk of dying earlier because smoking causes chronic conditions. You've probably all seen this, the benefits from smoking cessation with time since quitting. The moment you quit smoking, within minutes, you start seeing differences. Within 8 hours, oxygen levels return to normal, carbon monoxide levels in the blood reduced by half. Going on to 72 hours, breathing is easier. 3 to 9 months, coughing and wheezing declines. At 1 year, excess risk of heart attack reduced by half. So you can see the benefits are tremendous. Of course, there are different quitting methods. Local stop smoking services use definitely has huge benefit. Using stop smoking medicines prescribed also doubles the chances of quitting. The use of e-cigarettes is a bit kind of not consensus around that. In the UK, we actually use it, and we think it is 1.5 times as likely a person will succeed. And willpower without any of this, of course, is another method, but it's least effective, but it works. I've seen so many people by willpower quitting. This is not a lecture about smoking cessation, so I'm just highlighting what's out there can be used to help with smoking. Probably penicillin is probably at the moment the most common, and along with nicotine replacement therapy to aid that. So the e-cigarettes is also something that we do consider as an option for helping quitting smoking. It probably not without its risks, and that's why the European Society of Cardiology and some European countries have issues with e-cigarettes, because while they do help you quit smoking, but if you continue to use them, they have other complications where they increase blood pressure, and they seem to also have other harmful effects that you may want to think. And therefore, the best thing is full smoking cessation, which reduces CVD risk and overall cardiovascular risk as well. So that's kind of smoking, one of the most important probably risk factors that needs to be tackled. The next is unhealthy diet, and that's including high intake of salt and the likes. So poor diet is a significant contributor to chronic conditions worldwide. And the high intake of saturated fats, trans fats, sugar and salt, and low intake of fruits and vegetables drive multiple chronic conditions. And I guess the opposite statement, it would be correct. If you have high intake of fruits and vegetables, low salt, low sugar, not take any trans fats or low intake trans fats and low levels of saturated fats, then the likelihood of developing chronic conditions is likely to be less. So cardiovascular disease, poor diet is a leading risk factor for cardiovascular disease, including stroke as well. 30% of deaths from cardiovascular disease were attributed to poor diet, directly and indirectly leading to the development of other risk factors, which leads to exacerbation of cardiovascular disease. Same thing with diabetes, obesity, poor diet, physical inactivity, primary cause of obesity, increases the risk of multiple chronic conditions, and of course cancer, specifically low fruit and vegetable intake and high consumption of processed foods are strongly linked to the risk of certain cancers. Poor diet is linked to about 10% of all cancer cases globally, and about 50% of cancers thought to be preventable. 30-50% of cancer thought to be preventable through lifestyle changes, one of which is diet. There's a huge global impact, and it's a significant public concern. Therefore, diet is one of the very important targets for lifestyle changes that can make a huge difference. So I just broke it down to a few components. Excessive sugar, too much sugar increases inflammation. There's an interesting study looking about how excessive consumption of dietary sugar seems to trigger plenty of inflammatory processes in the body. And also it can lead to the development of several chronic conditions, whether it's diabetes, cardiovascular disease, obesity, metabolic syndrome, and of course, dental health is compromised, which has links to cardiovascular disease and other conditions as well. The second thing is excessive salt. We know there is a whole campaign and government policy around salt, cutting salt reduction, and there's estimated nearly 2 million deaths per year that are associated with consuming too much sodium globally. And There's plenty of studies where showing that consuming an extra 5 grams of salt per day increases your risk of cardiovascular disease by 70% and stroke by 23%. On the other side, if you limit your salt intake, reduce it by 2.5 grams a day, you're going to cut your cardiovascular risk by 20%. And probably the majority of the benefit would be driven by lowering blood pressure. What is interesting is that most of the studies, women seem to be more sensitive to sodium than men, and therefore they may have a greater outcome benefit when receiving comparable sodium restricted diets. CKD is another complication of high salt intake. One way, probably mechanism, is by increase in blood pressure, but also proteinuria and fluid retention. There is some evidence that linking high salt intake and increased risk of gastric cancer and osteoporosis is another one. And the recommendations are heavy around this, around cutting down to less than 6 grams of salt. And if you're looking about sodium levels, then less than 2.5 grams of sodium per day. We seem to be doing better compared to the US, but we can still do better in meeting that target because we are on average using about 8.5 grams in the UK. So that's salt. The next thing that we tend to talk about is fatty acids. Generally speaking, we don't like trans fatty acids because they have unfavorable outcomes in cardiovascular disease, coronary heart disease, and other conditions as well. There's a huge association between them and multiple chronic conditions. While high use of saturated fat is not recommended, and generally we should cut down on saturated fat and replace it by alternative fats such as polyunsaturated fats, most favored. Monounsaturated fats are also better than saturated fats. And there is a huge debate in the literature around that about what should we replace our saturated fats with. But generally speaking, there is evidence to show that lower saturated fat usually would improve even reducing cholesterol and coronary heart disease events. Fish is recommended. It's interesting. Studies when it looked at fish oil did not perform as well compared to actual fish. So eating fish, particularly fish rich in polyunsaturated fat is once a week was associated with 16% lower risk of coronary artery disease. That's why we recommend eating about 2 to 4 times a week of that fish to reduce also your stroke risk. Not the same evidence for fish oil supplement, which is interesting. And the multiple studies when combined, there doesn't seem to be cardiovascular outcomes and mortality impact, though maybe coronary heart disease events were slightly reduced, but not like fish. So I beg the question whether probably eating fish is not necessarily the same as having oil fish. And there's also a debate around the Reduce-It trial, which used one type of oil, which is called ecosapient ethyl. That's for a different discussion, I guess, to explore. But this is, one of the tablets out there that you can use, which seems to have cardiovascular benefits. Most of the guidelines talk about patterns, so it's not just about one item or another. So these are the overall concepts. But one thing for sure, it seems that Mediterranean diet overall have been associated with reduction in atherosclerotic cardiovascular disease and also reducing the risk of developing overall cardiovascular disease when it have these components. And I know I am not an expert dietitian, but I know when our colleagues talk about Mediterranean diet, they say like what Mediterranean diet means to different people is different. And therefore, it's important to look at these studies with what did the Mediterranean diet actually include, because it isn't necessarily what people currently consume Mediterranean diet versus what was included in the studies. So really important to think about that element. But Mediterranean diet generally is defined, as I mentioned above there, here in this diagram, where you're limiting certain elements and using certain elements a bit more, but kind of tallies with most of the description we've been giving so far. This is the European Society of Cardiology recommendation on cardiovascular disease prevention, what diet looks like. They favor plant diet over animal-based food patterns. So they recommend reducing animal-based foods and increasing plant-based foods. And saturated fat should be reduced to less than 10% and replaced with alternative mono or poly saturated fat or carbs, but not in excess. Trans and saturated fats are not favored. Lower your salt and increase your fruit and vegetables intake. Eat more fish and limit your alcohol intake, which I'm going to talk about in a second. What is interesting is the last bit here is not just sugar, but also sweetened beverages also had some negative outcome generally, which is quite interesting. Not the same as sugared beverages, of course, not as actual sugar, but even sweetened beverages, there's some studies controversy around it. So moving on swiftly to another risk factor, which is, I know it's part of our diet, so I include it in the diet. Alcohol. Alcohol is a leading risk factor for chronic diseases and injuries worldwide. There's 3 million deaths annually globally due to alcohol misuse and excessive use. Alcohol use is linked to over 200 disease and injury conditions and chronic conditions, whether it is liver disease, whether it's CVD, whether it is cancers. It's thought that alcohol causes about 740,000 new cancer cases annually. That's globally. In the EU, it's responsible for 10% of all cancer cases in men and 3% in women. And of course, it has major impacts on mental health as well. So there's a huge amount that needs to be done around alcohol regulating and having policy action. And in the absence of any control and around alcohol use, it is one of the very harmful elements that can lead to loads of chronic conditions. And that's why it needs to be well controlled and heavily regulated and policy controlled. This is some data from the UK and England specific, that 20% of adult population in England regularly drink at level that increases their risk of ill health. We talk about 14 units a week, not to have in one day, of course, but spread over the week. So no binge drinking, but a large proportion of the population don't adhere to these guidelines and recommendations. And of course, deprived areas seems to consume more alcohol than less deprived areas. And the other problem we have with alcohol is, of course, addiction and dependency, which is another problem to deal with. Not to forget its association with dementia, and that reducing your alcohol consumption by less than 21 units per week prevents or delays 1% of dementia cases. Of course, the association with psychiatric disorders is there, and alcohol use disorders quite significant in primary care. So there was always a debate about if there is any benefit for alcohol beverages in cardiovascular disease, and I've intentionally included that diagram saying about the theories, which was thought to be what the benefit could be. But the most recent cardiology guideline seems to lean towards not talking about that because of Mendelian randomization studies, which basically don't seem to support the apparently assumed protective effect of moderate amounts of alcohol versus no alcohol in terms of atherosclerotic cardiovascular disease. basically most of the cumulative studies when put together, seems to suggest that lowest risk for CVD outcomes are in abstainers, incomparable risk factors, of course, and that any amount of alcohol uniformly increases blood pressure and BMI. So the newer cardiology guidelines lean towards not recommending at all the kind of moderate alcohol consumption, even within the recommended limits, for the purpose of reducing cardiovascular risk. So if somebody doesn't drink, we don't encourage them to drink to reduce their cardiovascular risk, but it's like because the evidence shows otherwise in terms of versus those who are abstaining. So that's kind of alcohol. Just quickly sweeping through insufficient physical activity. Sedentary time is associated with a lot of chronic diseases and mortality. These are some conditions that contribute to whether it is diabetes, cardiovascular disease, dementia, cancer, depression, and pain, and also musculoskeletal symptoms. So physical activity is one of the most important activities that you can do to reduce the burden of chronic conditions. If you think about it, there's about nearly 2 billion adults worldwide who do not really do the minimum recommended physical activity. That's almost a third of the population of the world. And that's kind of our lifestyles have changed tremendously, that we became so inactive. That is probably one of the risk factors driving many of the chronic conditions that we are developing, whether it is cardiovascular disease, whether it is diabetes, whether it is cancers, and whether it is mental health. And the recommendation of the World Health Organization is that you engage for at least 150 minutes of moderate intensity aerobic activity per week. You can divide it onto the week or over 3 days. Of course, if you're doing vigorous activity, then 75 minutes. But it doesn't have to be, vigorous. Could be something like walking and gaining steps. So there's plenty around that, looking at physical activity in midlife, help prevent delaying dementia as well. And the ESC has some recommendations around that as well, talking about similar what we highlighted. What we say, walking for half an hour, 3 times a week, getting about 5,000 to 7,000 steps a day, something that would has been associated with lower risk of developing multiple chronic conditions as well. So a lot of the guidelines that you will look at, you will notice that they are referring to different types of activities and like avoiding sedentary lifestyle, being more active, but also, and that's of course reduces blood pressure, and also like reducing salt intake, not smoking. All the guidelines talked about that. I'm going to skim through this. I don't want to focus on it, but I wanted to say that stress is also another thing. I know I haven't listed at the beginning. This is just to finish off. Stress is important. Poor sleep is important because insomnia, which is lack of sleep, can increase your risk of having cardiovascular disease by 45%. Depression can increase your risk of all-cause mortality and fatal coronary heart disease by about 50%. Anxiety is not good. Depression is not good. A lot of these stresses and mental health elements are very important, but worth highlighting that optimism and being very hopeful, it actually reduces your risk of having cardiovascular event by nearly 35%. So it's very, very important to have less stress and good health and well-being and psychologically as well. Sleep disorders are contributors to overall obesity. We're going to talk about in one of the talks. So just conclude. So driving healthy eating, physical activity, smoking cessation, reducing alcohol intake are drivers. There's much been talked about that in lifestyle medicine pillars, which highlight them in this diagram. And of course, lifestyles reduce your changes, reduce your cholesterol, reduce your blood pressure. And I want to finish by this diagram for the American Heart Association, which talks about the Life Essential 8. Eat healthy, stay active, get enough sleep, don't smoke, maintain healthy weight, control cholesterol, manage blood sugars, and keep blood pressure in healthy range, you will reduce your cardiovascular health, you reduce your cardiovascular risk of developing diseases a lot, but also reduce your risk of developing other chronic conditions. Thank you so much.
Thank you, Rani. That sets the scene beautifully for our next speaker. Helena Gregory is a pharmacist. She's the pharmacy and medicines lead in northeast North Cumbria. She is an experienced pharmacist who works in North Cumbria and has a vast experience working in community pharmacy and general practice. She also has a role in the ICB in that she is medicines and pharmacy lead for personalised care, so is ideally placed to talk to us about how to apply some of the information that we've heard in Rani's talk. Thank you, Helena.
Thank you so much, Jamie.
Slide.
Thank you, Rani. So that's appeared. That's good. I'm going to talk now about how to practically apply some of the things that Rani's talked through. I am going to have a little look at some of the evidence and the correlations between it before we begin. But just to start off with, I'm going to ask everybody just if you can navigate yourself either on the device that you're viewing this on or on a phone or something similar to slido.com. There's just a little bit of interaction, so it'll just keep you going as we go through. If you can keep it going, because we do use it right through to the very end, so don't close it down. So it is on the next slide, but as many of you will know, when we start to talk about patients, we have to think about ourselves first of all, and we have to be able to put ourselves in the position of the patient and to empathise with them. And to do that, when we're thinking about what matters to you, my question to you today is, what's important to you? Take that in whatever sense you like. So this will share anonymously. It won't have your name up against it. So please don't worry about that. And if you see someone else typing something you like, then please feel free to add to it. What are the things that are important to you? And we'll give people a little bit of time. We can start to see them coming in there. So family and health. I'm glad, being healthcare professionals, that health is in there. And some of the things that Rani mentioned as well, sleep, diet, these things are important to you. But there are some fantastic other ones, your hobbies, your spirituality, your experiences, being able to get out and do the things that we love to give us happiness. So if you just finish typing your sentence in there, so there's some brilliant examples. Just have a look, think about what you've put and think about what other people have put, because we are going to refer back to some of this as we go through. So there's some brilliant examples there of some of it's actually the risk factors that we talked about, but some of it is other things. Family and health, happiness are the biggest things that have come through there for you in what's important, and I'm sure we will all agree with that. Okay, I'm going to move on now just to have a quick little look at some of the evidence and thinking about life expectancy. So when we talk about morbidity and mortality is that longevity, that's how long we live, but how long do we live well? So thinking back to the last question that we talked about, having your health is the thing that enables you to spend time with the family, enables you to have those experiences, enables you to carry out your hobbies, to be able to get out. And women live longer than men, but they also spend more time in poor health than men. So you can see there we've got the life expectancy, which is how long you live, versus the healthy life expectancy. And this is having a look at the UK. But if you have a look at North East and Yorkshire data, which is more up to date than this, then we've got 82 years, just short of 82 years of life expectancy, but just over 52 years of healthy life expectancy. And that healthy life expectancy, that ability to do those things that we love, is actually dropping. It's a larger gap than England average. And that means that many of our people are living nearly 30 years in poor health, which can impact in lots of different ways. You know, your family, your fun, your career, the things that are really important to you. And Sorry, it's just clicked over. As Rani said, we've got a lot of data that tells us the biggest risk factors for morbidity and therefore for mortality. And we know this, our patients know this, it's common sense, there are no surprises. I'm sure everyone who comes through our door could reel this off. But some of it is becoming a little more nuanced now, and we're starting to understand, as Rani said, some of the calculations of more complexity and the effects of modifiable risk factors overlaid on the non-modifiable. But of course, studies don't equal reality, and the people who come through our doors are not robots where they can just stop that simple modifiable risk factor. And again, as Rani alluded to, there is an awful lot of crossover between the risk for metabolic disease and other conditions, the same things that appear on both cholesterol, diabetes, physical activity. So making changes in one place will bring benefits for another. And actually, that's something to remember in our consultations, because different things will be important for different people. We might know somebody, for example, who actually isn't that worried about dementia, but is really worried about heart disease. And actually, saying to them that helping with one will helping with both might just be that lever to help them make the change. And again, we've got intersectionality in terms of the combined effects. So this research from Stirling University shows that the effects of smoking and alcohol on cancers, as was mentioned, is almost 4 times greater than adding the effect of the two together on its own. And similar for liver disease, the combined effect of alcohol and excess weight is greater than just taking each one on its own. So what does this mean in practice? Well, actually, it means that by stopping one, you have a greater effect, which is really positive, because you're reducing that risk down. But we do probably have a lot more people at risk than we think about. And so as you're working through and as we walk through the example, you'll see how some of that comes into play. So thinking back to what we talked about, staying healthy and keeping well was something that was really important for many of you. And many of you put similar things, but we also recognise that many of you put different things. But if we can use that again to find the lever, to find the motivation, by engaging our professional curiosity and just asking a few questions, taking people sometimes a step back beyond the obvious, we can start to think about how to support them. And because you're frontline healthcare professionals, you've got very busy clinics, you've got structured medication reviews, you've got a set length of time that you're going to see them, and you're not necessarily the expert in everything. So some of you may have heard about the brief intervention technique, and that's what we're going to go through today, which is a 5-minute quick, where are we at, using 5 A's to support a patient who's come to us. It's a short, structured counselling via motivational interviewing, and it's very much person-centred conversation strategy. Now, you've got have some self-motivated people who will manage this independently. They won't need much input. You'll do the intervention and off they go. Some people will need supported self-management and expert support. We'll try and cover a little bit of that today, but when we come to the inequalities webinar later on, we'll cover that in a little bit more depth. And in today's example, I want to think about movement and activity and just have a real focus on that. So within your practice, you've got Lisa. She's coming to see you for a health check. Her cholesterol tests come back a bit high. Don't worry about the numbers. We're not going to go into that. And you've identified her as a higher risk of heart disease. So using that brief intervention, we actually take that step back from launching into our information about cholesterol, and we say, what do you know about it? And she might tell us a little bit about what she knows. Now, she might know an awful lot. She might be a cardiology specialist herself. Equally, she might know absolutely nothing and, struggle in some cases to even spell that out if she was going to do a Google search on it. So it just gives you that opportunity to identify somebody. Where are they at today? What's their level of interest? What's their level of understanding? What's the health literacy, so that you can pitch it right? And quite often their response will give you an open invitation to describe the risk factors of heart disease and how cholesterol can contribute, because you're helping her take that step back. What do you know about it? It's bad for my heart. Oh, right, okay. Let's talk a little bit more about that and just open that conversation up for you. Then you can go in to start to describe some of those risk factors, and we'll have a look at that in just a moment. So again, there's more information on this when we do did the lipid optimization webinar. So if you've not seen it, you might want to refer back to it to go through this in more detail. So you might be showing tweaked Q risk 3 to talk about her heart risk and the things that affect it. You might be ticking and unticking boxes to see the little smiley faces change, to see more smiley faces, fewer smiley faces. What are the things that make the biggest difference? So, you know, taking a statin, for example, and the cholesterol improves, and we're on track with that. But equally, you might find that if somebody's got lower health literacy, actually going through something like Heart UK and having a look at this diagram might be a little bit simpler and more straightforward for them, because you can point at them and see what they would like to know more about. So you can talk through those. And as I say, do listen to the other webinar if you want to know this in a little bit more detail. So having given that advice, you then want to know how it lands with somebody. You want to understand where they're coming from before you start launching in again with your advice. So you've picked up potentially as out of this on a wish to increase their physical activity. And they might say this in different ways. So they might want to move more, they might want to become more active, they might want to exercise. Again, thinking about where they're at the moment is really helpful, because you're not going to ask somebody to run a marathon if actually getting themselves to the shops is really challenging, and vice versa. But actually, if you just stuck to asking about cholesterol, you'd never have discovered this. So your curiosity in this case, in that brief intervention, has got you somewhere. But now you have to give the advice. So that, again, is the challenging bit if you're not the expert in physical activity. Maybe in a case of a pharmacist, you might be the expert in the statin. So what do you do next? So we're still on that brief intervention, still on those 5 steps. So this is the behaviour change model. Many of you might have seen this before. It's used in a number of different things, so smoking cessation, for example, but any of the risk factor, the modifiable risk factors, you can use this behaviour change model. And it's really good to kind of keep it in your head while you're discussing with someone, because you want to understand where they're at. And asking that question about how does that land with you will give you a bit of a figure of where they're at. Now, when you're taught this, I was taught this in smoking cessation about 20 years ago, and I was taught everyone's at 0.1 or 2. And actually, I've recognised when I've experienced that, they're not at 0.1 or 2. So we shouldn't assume where people are. They might tell us, but we might have to ask them, how's it landed with them? Where are they at the moment? So in many cases, people know about the risk factor. We've talked about that. And they might have tried and failed to do something about it numerous times. So we need to give them a really supportive approach. So just that little word before we dive in with the action of, that sounds really hard, or I can understand where you're coming from. So if somebody's had, for example, yo-yo weight loss, they might be at 4 already. They might not physically look like they're at 4. So they might be, you know, living with overweight or obesity, for example, but they're trying really hard. And actually, before diving into the advice that they're like, I know this, we can just take that opportunity just to build that confidence and hear about what they're doing. Perhaps put them on the right track if they're struggling a bit, if they're relapsing a bit, and they're at 0.6. Actually, they need to rebuild that confidence of, we can have a go. Let's have a go together. Let's see what we can do. But also, you know, again, thinking about point 3, the planning and the preparation. So that's really important for people to do. So we mustn't dive from thinking about it straight into the action. We just need to think about the preparation to get the best chance of success. So you might, for example, think, well, what will your change feel like? How would that fit into your day? Because everybody has a different 24 hours. And if you know, for example, you have a family and you're having to spend time looking after them, or you have long hours in your job, then you really need to think about, is it going to fit into your day? And if so, how? So back to Lisa. We've decided what Lisa would like to do. She's going to increase her movement and activity levels, and we can now move on to assist and arrange by recognising the enablers and the barriers to signpost effectively. So you might ask questions, as we've said, how would that fit in your day? What are the things that you enjoy doing? Are there things that are getting in the way of it? Just so, again, that we can understand where she's coming from before we launch into our information giving. And equally, when you're arranging something and signposting, then what would people like to do? And I'll come on to some of the evidence behind that shortly. Equally, Lisa might decide that it's not for her right now. You've sown the seed, maybe she's in relapse, but she trusts you and she can come back to you. So I'm just going to ask you to think now, keep your Slido open because I'm just going to go back to it so that you can input into it. What would you say to someone who gets to this point? They're not interested in change. What would you say if that person was sat in front of you? And I'm sure that there have been many times, just to reassure them. So I'm going to put that up and there's an opportunity there just to type into the Slido. How would we respond to them so that they know that we're open to them? And some good ideas coming in here. I can tell you guys have these folks in front of you all the time. Because we want to make sure that however they go away knowing that the door is open. Oh, if you would like help in the future, please come back. Fantastic. The door is always open. I understand. That's brilliant. Taking that moment, making them aware of things that they can come back to and have a look at in their own time. Do they want to book a future appointment in? Love that one. And there's some examples there of things that we can use when we're in the advice section as well. What does she think will help? Okay, good. Some great examples there for you to take away and to use in your own practice. So that's really good. It can be hard to do it without support. Can I help? Yeah. Excellent. Okay, thank you very much for contributing those. So I hope that's given you some good ideas to take away. Let's just have a look what people think about exercise. This is from a survey of around 1,000 people living with long-term conditions and the organisations that support them. And Rani's gone through the types of exercise that we need to do. But if you've got a long-term condition, that could be really hard for you. Just getting out of the door could be really hard for you. So people know about the risk factors. So almost everybody, when they're asked, knows that it's important to be physically active. That's the first thing to say. This is no surprise to anybody at all. They know this. So actually, we need to understand their motivations. What do they want to do? What will the benefits be? So that we can think through when we're kind of almost selling it to them around some of the things that will help. So their physical health and fitness, being able to get out, being able to take part in their hobbies, having that strength to walk the dog, their symptom management, to be able to help with that. So their back issues, for example, they really want to improve. They really want to get better. And a lot of people also cite their mental health. So being able to get out, get some fresh air, clear the head, actually that might be a really important goal for somebody, just to be able to walk their dog. So it's about meeting them where they are at and being able to help them identify those benefits. On the other side, there are barriers, but they're not always what they think we are. So this was a bit of a surprise to me, this report, because in many cases, I'd thought, for example, it might be about the cost. Some healthcare professionals think that it's about the motivation and mindset, but in many cases it's not. It's the pain, the fatigue, and the physical limitations that are actually the biggest block to people. So, for example, with our language, again, we're not going to ask them to run a marathon if that feels impossible to them. Who knows where the future lies, but for now, let's just set a more effective goal. And what would help? So signposting for specialist support, I'll show you how to do that shortly, but also having examples of materials. And somebody suggested that in the last one, are the materials that we can give for people to take away. And for a lot of self-motivated people, that might be enough. So a lot of people actually wanted things that were digital, workout libraries, online inspiration, peer communities, and that level of support to do that. So just by flipping and understanding what's important to the person sat in front of us and not what we think is, we can actually make a real difference in their motivation and how we provide that. And we can support them in a number of different ways. So just as the risk factors of individuals, so is accessing that expert advice. Does your patient prefer online information, or would they like to speak to a health and wellbeing coach? So in a lot of areas now, you will have a health and wellbeing coach either through your council or through your primary care network, and they will be able to support somebody to improve their overall health and wellbeing using that health coaching style and scaffold it for them. They are the expert who will be able to do it alongside that person, encouraging them to achieve, to set and to achieve goals and to change that. So do go about finding yours. If you've got a social prescriber, they'll usually know who they are, or a care coordinator, they'll usually know who they are and be able to tell you how you can refer to them. But equally, there can be barriers within that. Some people, as we've said, prefer online, and there are online campaigns now. So 2 of them are We Are Undefeatable, which we've talked about before for people with chronic conditions, or This Girl Can, which is for females. And again, they provide a lot of role modelling and scaffolded online support for people who don't usually exercise, just to help them get moving. So do have a look at their campaigns. And it wouldn't be a webinar with me if I didn't mention Morning Live and their movement section with their standing and seated exercises. So there's something there on TV that people can access as well. So make sure that you signpost to these reputable sources, because if you don't, you're going to get the folks with the quick fixes. And this stuff is really hard. And it's really, really hard for people who have it really, really hard. So we'll cover that more in our inequalities webinar. And I recognise what I've been through today is a bit more of an ideal scenario. So lifestyle risk factors and medicines can be really hard sometimes for people to tell fact from fiction. It can be hard for us, and it's even harder for the public. So there were just a few examples of that. So medicines alone are not going to be as effective as the whole treatment plan. We've heard how the lifestyle factors can affect it. So we should make sure that we explore those as we've discussed, and encourage people to use it and record it as part of people's treatment plans so that we can refer back to it later on. They will work better together than one thing on its own. And what I call a bit of the wellness woo, so where you've got misinterpreted evidence, very low grade evidence, such as a case study, or you've got fake news. So, for example, supplement sellers, there's quite a fine line between the reputable evidence around some supplements and the less reputable information. So people might just be tempted, if we're not giving them the right information, to try that quick fix, which may not work for them. And then there's the sort of misinformation and fake news. And that's a huge spectrum, from somebody who's joking, who's been suddenly taken seriously by someone who didn't get the context, through again to some very poor quality studies by people who shout very loudly or misinterpret them, or in some cases have something to sell. So just to be wary of that when you are having these lifestyle risk factor conversations, that you might need to have conversations around this as well. And there's a good couple of links there if you want to read up on it a little bit more. So that's given us a whistle stop tour through Lisa and her example, and how we can have a look at physical activity in practice through that brief intervention 5-step model with the 5 A's. So I'm going to finish up there because we're heading rapidly for 2 o'clock, and I'm going to go back to Slido one last time and just ask you, what will you take away from today? Let us know in there. Again, it is completely confidential, so you can write whatever you like about what Rani and I have shared today, and give each other some really good ideas to finish up. So I'm just going to leave that up in the background while I hand back to Jane.
Thank you, Helena. That's excellent. We've got 2 minutes, and there is one question. There are lots of comments in the chat. They're very complimentary ones. Thank you for those. But there is a question for both speakers. Given the challenge in access to primary care and the seemingly worsening picture of CVD risk, what needs to happen, and B, what realistically will happen in the next few years? Helena, can I give that one to you?
Yeah, I agree. The access to primary care is very difficult at the moment, and we recognise that, there is the left shift at a very high policy level, which we hope is going to support a lot of this work and open up some of the funding organisations and opportunities for it. But I think that is going to take time. I think in the short term, there is an awful lot in communities that is already there that people don't know how to access. And our social prescribing link workers are fantastic for lining some of that up. So I think they are one of the most underrated resources that we've got in our primary care networks, who can support linking things up and ask them to work for you. So if you're struggling with a particular type of service or risk factor, then ask them, and I'm sure they will be happy to help.
Thank you, Helena. Right, we're bang on 2:00, so I'll end the session there. The next webinar is heart failure and CKD, and there are links for you to register for that. So thank you all very much for participating today. Reminder, if you want to refresh your memories, then you can view the slides, and there will be a recording of the presentation circulated, and we'll also be asking for your evaluation of the session. So if you wouldn't mind completing that for us, we do take notice of it, and that our planning of this series of webinars has come as a consequence of looking at the feedback you've given us on the first series we did. So thank you all. Goodbye.